Welcome to the 213th episode of the Jami Dulaney Plant-Based Wellness Podcast. My name is Jami Dulaney, and I'm your host. I'm a plant-based cardiologist and endurance athlete living in Southwest Florida. Welcome. Well, our book's out, doing well, and we're getting a lot of nice Amazon reviews. If you haven't ordered your book, please go to Amazon and check it out. It's the Plant-Based Wellness Cookbook, 3 Generations of Plant-Based Cooking, the Doctor, the Dietitian, and the Diva. Again, we've had a lot of people email us some pictures of photos of the recipes they prepared, and we're getting a lot of good feedback and enjoying that. So if you haven't picked up your book, do so. And if you can give us a review on Amazon, we'd love to hear it. You can even send us a little email with a picture that you've taken of something you prepared. So I hope that everybody's enjoying the cookbook. Today I have a guest, Patrick Mckeown. Patrick wrote a book called The Oxygen Advantage, and it's a very fascinating book. I have become more and more interested in breathing techniques, how it impacts my members and patients, as well as health in general, as well as athletic performance. And I've been doing a lot of reading and stumbled upon his book and found it very interesting and reached out. He's agreed to speak with me. You know, just like in medical school, everybody talks about doctors don't get much in the way of nutrition education. Well, they don't get much in the way of breathing education. We learn the basics, just like we do in nutrition, as far as, you know, what your lungs are, where they are, how they're innervated, what they look like, and the general function, and how to do testing, how to cut them out, how to treat them if there is an infection. But as far as connecting all the parts and how it relates to our autonomic nervous system, how it might relate to our immune system, how it relates to athletic performance, we don't get a whole lot. And Patrick goes into a lot of this in his book, and he and I also chat about sleep apnea. It's such a common diagnosis in people these days, and everybody's just prescribed a CPAP mask, and then they go on about their business, kind of like you're prescribed cardiac medications and you go on about your business. But is that really helping people in the long run? It puts a Band-Aid on it and keeps our oxygen from desaturation. But is there a role for breath training in helping to reverse sleep apnea? We know that weight loss helps reverse some sleep apneas, but as Patrick and I will get into, there may be a role for breath training and respiratory muscle training to help reverse sleep apnea or improve it. And, just in general, we look at our practice of people they breathe right? Do you get adequate ventilation? We often say, take a deep breath, but that's not really what we should be doing. And sometimes that deep breath is just blowing off carbon dioxide, and it doesn't do us all that well. So it's more of an effective breath or an effective respiration. And Patrick likes to talk about breathe light to breathe right and breathe through the diaphragm. So again, we'll talk about that, and then we'll go on to actually see how this translates into athletic performance. How it can improve our oxygen consumption and our metabolism so that we can actually perform better athletically. So I think you'll enjoy this podcast as I did, enough to actually go back and listen to the whole thing. I learned a lot, and I think we'll be exploring it a whole lot more in our practice. So I hope you enjoy it. Patrick, again, the book is The Oxygen Advantage, and I'll put links to all of his website and how you can get in touch with Patrick after the interview. So please enjoy. Well, today I have the pleasure and honor of interviewing Patrick Mckeown. I, as most people know, I'm a cardiologist and endurance athlete, and we're always looking for ways to improve our athletic performance and general overall health. And I stumbled across some breathing by a guy named Wim Hof, who's known as the Iceman. And this guy was pretty radical, sitting on ice, breathing, and but he had some things that intrigued me, so I started reading more and more. And that led me to this book called The Oxygen Advantage by Patrick Mckeown. And Patrick, you write so eloquently, and the book explains things in such great detail. So I'd like to share your journey, and we can just kind of jump right in how you got started and go right to that Bolt test, I guess is how it all goes.
I came across this by accident. Basically, I had asthma since I was a very young child, and with that I had chronic nasal obstruction. And since 2007, it's been recognized that the airway is a unified airway. So if there's inflammation in the lungs, it can travel up to the nose. And if there's inflammation in the nose, it travels down to the lungs. And with that, if your nose is stuffy and if you mouth breathe, your sleep is impacted. So you've got a greater increased risk then of sleep disorders, including obstructive sleep apnea. So in a nutshell, I was wheezy, I was caught for breath, I had exercise intolerance, my sleep was affected, my concentration was affected. And, you suppose you grow accustomed to it and you learn to kind of cope with it. And that was, during childhood, into my teenage years, into my early 20s. I completed my university degree. And then I came across a newspaper article about two things: the importance of breathing through your nose and the importance of breathing functionally or breathing light. So I started on that journey, and then I switched careers. So I trained then in breathing, and I've been doing this since 2002.
It's very interesting. When I observe people in my office, especially older folks, they tend to breathe very shallow, up only through their upper chest. And it's funny, in medical school, and nurses will record respiration rate, and people will just nobody cares, and they put down 18, 16, and you pointed out that that's way too high.
Yeah, it really, really doesn't make sense. A lot of doctors, when they're seeing individuals with, say, chronic heart failure, they'll put down exercise intolerance due to the chronic heart failure. But they don't always consider that this individual may have a strong chemosensitivity to carbon dioxide. And they don't also consider, how can you functionally breathe to improve oxygen uptake in the blood? Now, shallow breathing, we see it all the time. I see it in asthma, and we see it in people who are unwell, and I see it in people with anxiety. And if we're breathing shallow and if we're taking air just into the upper lobes of the lungs, we're not going to have a good gas exchange, or at least we can improve it if we bring the air deeper into the lungs, because there's a greater concentration of blood in the lower lobes. And when you breathe through your nose, you pick up nitric oxide, and nitric oxide laden air as it's taken into the lungs will help to distribute the blood throughout the lungs. So a better gas exchange takes place, and this improves oxygen uptake by 10%. So, for example, if I'm working with a client and if they have got poor breathing, and if I see them desaturate quite quickly during physical exercise, I'm wondering, can I improve their breathing efficiency to increase their blood oxygen saturation? And we can. Two ways. One is by slow, light, deep breathing using the diaphragm. And I'm not talking about taking big breaths, because that's often...
everybody wants to go...
And the second way is to slow down the cadence of the breath during rest, maybe to 6 breaths per minute, because so much air that every breath that we take, we lose 150 mil to dead space. And there's a 20% efficiency increase in breathing by switching and changing to cadence breathing. So to give you an example, and these aren't my ideas, I was giving a podcast recently, so I had, it written here. But it was from a cardiologist from Italy called Bernardi. Mm-hmm. And he's got 500 papers on PubMed about the benefits of slow breathing. And I think there's such a connection with what we're doing and cardiovascular health and respiratory health and the connection between the two. But in simple terms, if we are breathing, say 12 breaths per minute, I'm not sure if you can see that.
Yes, I can.
And if each breath is a half a litre, well, then we're taking 6 litres of air in through whether the nose or the mouth or whatever. But of that 12 breaths, 4.2 litres, 4.2 litres reaches the small air sacs in the lungs. Now, if we switch that to 6 breaths, with deduction of dead space, so instead of 1,000 mil per breath, we're dropping it down to 850 because of dead space, we're increasing the amount of oxygen or air that reaches the lungs to 5.1. So there's a 4.2 per the same minute ventilation. We can increase the amount of air that's reaching the small air sacs by simply slowing down the respiratory rate. So I agree with you. People are looking at the respiratory rate, but they don't consider it. Like even Jami, in terms of mouth and nose breathing, nobody is considering it, or at least very few healthcare professionals. And I think it's time that we started looking at it.
Oh, yeah. And I mean, since I read your book, I read something and apply it, and I watch and talk to everybody. And, I ask them, do you sleep with your mouth open?
Yes.
Where's your tongue right now?
Yes.
And no one is, no one's ever asked. And, I think that, there's so many people diagnosed with sleep apnea. And the first thing that happens is they stick a mask on them, and nothing is ever done. And what I wanted to explore is how much of that do we really need to just stick a mask on people, and how much of that could be improved by retraining how people breathe?
I think that the mask should be a last resort. I think it's not addressing the issue. Sleep medicine has changed very considerably in the last 4 years. So up for so many years since the 1970s, sleep apnea was considered primarily an anatomical issue, that the airway was too small, the jaws were set back, and the airway was compromised. But since 2014, there's recognition now that there's 4 phenotypes or 4 traits. Only one of them is anatomical, and 3 are non-anatomical. So anatomical one is peak rate, which is the pressure at which the airway is collapsing. And you don't want the airway to collapse with a low suction pressure. It's a problem. But a second one is loop gain. And loop gain is the chemosensitivity of the body to the buildup of carbon dioxide. And it's measured using breath hold time. And 30% of obstructive sleep apnea patients are predisposed to high loop gain. And this means that because they have a sensitivity or a strong sensitivity to the buildup of carbon dioxide, when they stop breathing, when they resume breathing after the stopping of the breath, they resume breathing with very strong ventilation, and this feeds into the next cycle of apneas. So the condition is feeding in on itself.
Okay.
So you can help determine. There's a paper by a Harvard doctor called Mckeown, which was published last year, and it's the first paper of its time because I suppose the whole field of sleep medicine is changing so much. But breath hold time measured will determine, or at least help determine, whether the individual has got high loop gain or not. Now, another phenotype is called arousal threshold. And arousal threshold is the propensity to wake from sleep. Is the individual a light sleeper? Are they waking up so easy? And this is causing sleep fragmentation. And a paper showed that the greatest risk of mortality were with individuals with low arousal thresholds. And currently doctors are prescribing sedatives to help improve arousal threshold. But if you breathe through your nose, and if you breathe using your diaphragm, and if you breathe slowly, your sleep is deeper. And nasal breathing is getting more attention, especially with Dr. Christian Guilleminault. He coined the phrase obstructive sleep apnea back in the 70s. And he also came up with the apnea-hypopnea index. And he is talking about the critical importance of restoring nasal breathing. Now, he's talking very much about pediatrics. However, we can still translate this into information to adults. I don't believe that anybody should be sleeping with their mouth open. And the resistance to breathing is 2.5 times that breathing through the mouth during sleep versus breathing through the nose. Now, with that, of course, we want to get the nose open. And individuals with smaller nostrils or compromised nostrils, they may need to use a nasal dilator. But even still, these are small things to help open the airway. And I really liked that you mentioned the position of the tongue. The tongue has got 2 places to be. It's either in the roof of the mouth or it's falling into the throat. So we really need to make sure that the lips are together and the tongue is resting up in the roof of the mouth, because then we're maximizing airway space, and we don't have much room for error here. A good airway is the size of your thumb. And, with the sites of collapse there. But there's another phenotype called upper airway recruitment, and that's how do you get the upper airway dilator muscles doing their job? How do you get these muscles in the throat, in the airway, to keep the airway open during sleep? And myofunctional therapy is getting a lot of acceptance in terms of both in the United States and also in Europe, with the recognition that there's exercises designed to improve the tone of the throat and the tongue, and to kind of, like, we don't exercise this part of the body, and as we get older, we lose muscle tone. So it doesn't function. So there are exercises to help develop this. And also a didgeridoo playing a didgeridoo has been shown to help. But the other one final thing I'll mention is the link between the upper airway dilator muscles. I talked about the airway as being a unified airway. Your diaphragm is linked with the upper airway dilator muscles. If you breathe using the diaphragm, it increases lung volume and it causes a stiffening of the pharyngeal airway. So when we put on a bit of weight, once we hit 40 and the weight starts piling on, the diaphragm is impeded because it's not able to contract because of the abdominal, fat. And as a result of poor diaphragmatic function, the upper airway dilator muscles get lazy. So I think it all really ties hand in hand. Nose breathing, slow breathing, light breathing.
Yeah, I've been using, your cues as far as holding on to the ribs and, to have people watch, because I'll have them take a breath and they'll say, where did your hands go? Did they all go up or down, or did they go in or out?
Yes.
And of course, everybody, when I have them, be conscious of it, the first thing they do is take this, this big upper chest, and it's like, okay, so let's try it again. And then I've been actually measuring the Bolt score on everyone.
Great. That's excellent. I must send you on Messino's paper, because it will tell you the chemo. It gives you some idea of the feedback of the chemo sensitivity to the buildup of carbon dioxide and individuals with a low Bolt score. So traditionally, your breath hold time as a measurement or as feedback of the increase or the accumulation of CO2, the sensitivity of the body to it, it gives you feedback on the onset of breathlessness. So individuals with poor exercise tolerance will tend to have a lower breath hold time, but also individuals with sleep, high loop gain, but also individuals prone to panic disorder. They can have there's two subsets of individuals with panic disorder. One subset they have a very strong sensitivity to the accumulation of carbon dioxide, that feeling of suffocation. And what we want to do is, with exercise intolerance, with sleep apnea, and also with anxiety, is to reduce the chemosensitivity of the individual to the buildup of carbon dioxide, and then their breathing is lighter and their symptoms improve.
So let's just if you'll just explain the Bolt score to people.
Yes.
Real quick, and then I want to ask a couple questions about how this relates to a couple things.
Sure. The Bolt score is simple. You sit down for about 5 to 10 minutes. In other words, don't be moving about before you measure it. So you're sitting down resting, and you simply take a normal breath in through your nose, a normal breath out through your nose, and you pinch your nose with your fingers, and you time it. How long does it take until you feel the first involuntary contractions of your breathing muscles, or the first definite desire to breathe? We don't hold the breath for as long as possible. We're only holding the breath up until the point that the respiratory center in the brain, or at least the body, reacts to the breath hold. So the first signs to resume breathing. And when you resume breathing, your breathing should be fairly normal. Now, if it's a little bit over, I wouldn't be worried about it, because it's not always easy to get perfect. But bear in mind, yes, you're only holding the breath on an exhalation. So it's a normal breath in, normal breath out. You pinch your nose, hold your nose, and you're timing it in seconds until you feel the first distinct reaction to breathe, and your breath should be normal when you resume breathing.
Great. So if people, I've had some sleep apnea people that have sleep apnea that actually have a long Bolt score, and I was somewhat surprised, that was going to be, and you kind of explained that on the other end of things because of that feedback loop that people tend to. So explain to me, with sleep apnea, just to kind of clarify it for everybody, it's an abnormal oxygen desaturation during sleep, multiple episodes for a particular period of time. That's probably the quick, simple answer. Yes. And so instead of most of us breathe, because we are CO2 tolerant, so our oxygen saturation doesn't decline, but but the CO2, and that's when we take a breath. But people with sleep apnea, their oxygen will actually decline, despite the CO2 going up. So explain to me the Bolt score in some of these people with sleep apnea that have a normal Bolt score.
Yes. Normally with sleep apnea, you will expect a reduced breath hold time. It is normal. However, because the individual is stopping breathing during sleep, they can have blunted chemoreceptors because of the condition. And it's not that they have, it's just that we can't rely on bolt score because the part of the brain, that the chemoreceptors are not monitoring the buildup of carbon dioxide. So we know that the chemoreceptors can restore when the individual goes on CPAP, in other words, when their apnea is reduced. So I really want, when somebody comes into me with sleep apnea, I measure their bolt score. But if I feel it's not accurate, in other words, if they're showing me a bolt score of 25 seconds, but I look at their breathing and I'm seeing fast upper chest breathing, I know that their bolt score isn't reflective of their breathing pattern. Mm-hmm. So I can't rely on their bolt score. Mm-hmm. So what I do then is I'm just working to change their breathing, to slow down their breath, to bring it to the diaphragm, but I ignore the bolt score. So when those individuals, and the other thing with those, when they have a blunted sensitivity to the accumulation of CO2, when you have them slow down their breathing, they don't tend to feel the air hunger in the initial stages. They don't feel a kind of a tolerable air hunger. They only feel the air hunger when it's extreme. So that will also tell me that, yes, that the body isn't reading the accumulation of CO2 as sensitive as it should be.
Does that get better then? Does that kind of reverse the other direction over time?
It does if we can reduce their apneas during their sleep.
I got you.
The papers showed that, yes, when the AHI reduces, the chemoreceptors, the function or the blunted chemoreceptors restore. Now, it's really coming back, like, as we were talking about, the gold standard of treatment is an individual does a sleep study. Now, a few things about the sleep study and the AHI index. It's not a perfect score. Number one is, say, for instance, the clustering of apneas. You could have one individual and they go to sleep and they have all of their apneas in the first 2 hours of sleep. But say for the next 6 hours, they got a good sleep. They've got 6 hours of good sleep. Whereas you have another individual, if their apneas are throughout the night, all of their entire sleep is fragmented. And that's a difference there, even though they'll have the same AHI, the same apnea-hypopnea index. Mm-hmm. Another aspect is, you could have one individual who is stopping breathing for a minute. That's one apnea. Or you can have another individual who has got many apneas, but they are smaller. The individual who is having many apneas will have a higher AHI, despite the first person who is stopping breathing for a minute. They may only have a low AHI, but they reach a very kind of low oxygen desaturation. Mm-hmm. A third thing is that we can't necessarily rely on the SpO2 or the SaO2% because carbon dioxide has a protective effect. When you do a stopping of the breath, your blood oxygen desaturates, but at the same time, carbon dioxide is increasing. And the increase to carbon dioxide is causing a right shift of the oxyhemoglobin dissociation curve to cause a further desaturation. But we're looking at that desaturation as a bad thing. But in reality, the increase of carbon dioxide has enabled or reduced the affinity of hemoglobin for oxygen. In other words, the increase of CO2 has encouraged more oxygen to be delivered to the tissues and organs that are using it. So I think the AHI index is not perfect. And of course, the big problem with the CPAP machine is compliance. Individuals from the higher socioeconomic groups tend to stick with it more. Individuals with lower socioeconomic groups tend not to. I think the background there is because if you're in a higher socioeconomic group, you might be working more in an office. You're working with your mind. And if you're sleepy, you're not going to function whatsoever. Whereas if you're working, say, as a tradesman or a building site or something like that, if you're working manually, even if you're tired, you'll get by with it. And I think that can be part of the reason. So, like, I would love to see research on the influence of nasal breathing, diaphragmatic breathing, and slow breathing with these groups of sleep apnea. And there has been no research to date on it. Bar Christian Guilleminault looking mainly at the pediatric population. I think it's crying out because we've been advocating this for 20 years and I've seen the results. And I seen it by accident because people used to coming into me with asthma. And then I talked to them and they were also sleepy. And as asthma increases, so does obstructive sleep apnea. So there's something going on there because normally you would consider, well, OSA is the upper airway and asthma is the lower airway. But how, when one gets worse, so does the other. And in 2016, there was a paper showing the bidirectional relationship between asthma and sleep apnea. When you treat asthma, you improve sleep apnea. And when you treat sleep apnea, you improve asthma. And also the relationship between the nose, sleep apnea and asthma. And I think from a breathing perspective, yeah, it's crying out for attention.
Yeah, there's so much. And then, you can even tie in, this is a plant-based nutrition practice. Yes. And so when we take dairy out of the diet, we make the body less acidic, then we're changing the pH of the blood. And that also affects respiration and asthma.
And there's no doubt that with quite a number of individuals, especially when they have rhinitis, it's not 100%, but certainly with a large percentage of individuals with rhinitis, they have an intolerance to dairy, or at least dairy doesn't suit them. It's producing more mucus. It's causing nasal stuffiness. So I think it's very important. Yeah, it's looking at the entirety of it and the food that we eat and simple things, and I don't know very much about nutrition, but I do be interested in the impact of nutrition on breathing. And we know that a processed diet has a negative impact on breathing. This was first documented back in the 1930s it was a dentist actually, by Dr. Weston Price. And he went to various civilizations. And when civilizations changed from their traditional diet that they were eating for thousands of years to a processed diet with sugar, he noticed that there was craniofacial changes and mouth breathing. And the whole impact, like my jaws are set back. My jaws were narrow. I had to get orthodontics, and I have a really compromised airway. My Mallampati score is 3 or 4. So I'm a prime candidate for sleep apnea. Mm-hmm. And I've been able to compensate. But my parents had really broad facial structures. They didn't have sleep problems. This is happening quickly in one generation. I was in Lithuania, and I'll just give you a small story. I was in Lithuania there working with a dental clinic, and the dentist there, they were a professor of dentistry from one of the universities. And she was tasked with this job of identifying skulls that they found inside in the city. So these were skulls of individuals who rebelled against the Russians back in 1917 or 18. The Russians found them, hung them, and just threw them into an open grave. So the open grave was discovered last year. The dentists were asked, please identify these individuals. And that's why they're looking at, faces, etc. We looked at the makeup, the craniofacial development of these individuals only 100 years ago. They had such forward growth of the jaws. It was amazing. There was plenty of space behind the molars. So therefore, we know they would have had a good airway. Nowadays, what is the human face like? The face is set back. The airway is compromised, and that's going to increase us with the risk of sleep apnea. And up to 50% of studied children are persistent mouth breathers. Nobody is talking to these kids about getting the mouth closed, get your tongue in the roof of the mouth, because the craniofacial development of these children is absolutely paramount to help ensure that they don't have a sleep problem for the rest of their life. And the link of this with cardiovascular health, as you know, is good sleep. It's better, less stress on the heart.
Well, and it's also interesting you tie that back to the soft food intake. We've become a civilization of everybody eats soft food, soft bread, processed meat, marshmallows, soft, off things. So kids don't learn to choose. They're not chewing apples. They're not chewing cabbage. But they don't have mashed potatoes, French fries, not, having to eat something. And that also impedes jaw development and goes all along with it. So my other confusion point a little bit is, okay, so when we progress, now if we go to more a little bit of the athletic aspect of it, and to improve VO2 max and to improve our CO2 tolerance, and there's some hypoxic training when we start to, I guess, get to get to that point. So we're actually breathing to drop our CO2. In the sleep apnea population, when that happens for, multiple episodes, what we see from a cardiovascular stance is dilatation of the right heart, pulmonary hypertension, and arrhythmias.
Yes.
So is there some balance here? Help me find the balance there.
Yes. We have to consider that obstructive sleep apnea is involuntary, and it can be happening many times an hour, many nights, over many months, many years. And this will have a stressful effect. This is not good. Whereas when we were doing breath holding, we do it with individuals with normal health. And this would be similar to, say, for instance, swimming in a swimming pool. That you're swimming down to the bottom of the pool, you're staying down there for a little bit, you're coming back up. That we're exposing the body to a slight stressor. And with that, we're getting the body then to make adaptations. So we are disturbing the blood pH. So what we want to deliberately do with this is that we have the individual breathe in through their nose, breathe out through their nose, pinch their nose. Then walk, then jog, then run. Build up a strong air hunger. You feel the involuntary contractions of your breathing muscles. You're disturbing the blood acid-base balance. And when the air hunger is pretty strong, let go but have minimal breathing for about 6 breaths to prolong the hypoxic hypercapnic response. In other words, to prolong the drop to oxygen and the increase to CO2, and then have normal breathing. And we do about 5 repetitions once or twice daily, and that's it. Mm-hmm. Whereas sleep apnea, your AHI, it's the minimum of 5 breath holds or 5 stopping of the breath per hour. And you could have individuals with up to 50, 60, So we're doing short term. It's a stimulus to cause the body to make adaptations, but it's under the radar that it wouldn't cause damage. And why would I say that? Well, I've looked at not all of the papers, but I've looked at quite a few papers that I could find on free diving. And free diving has been tested quite a lot, especially in Europe. A lot of the papers come from Sweden for some reason. It didn't see any issues in terms of the brain, in terms of the heart, etc., from doing free diving. So I just extrapolated that information, to using what we do. The other thing is, if somebody does strong breath holds, their heart rate should normalize within about 10 minutes of the final breath hold. Mm-hmm. But if they find that the heart rate, if it's causing, say, arrhythmia, fluttering, or if it's causing palpitations or tachycardia, they have to stop doing the strong breath holds. So there may be some neuroplasticity there. If you can imagine an individual who, say, has undiagnosed sleep apnea, and when they stop breathing during sleep, it causes these changes, a sympathetic activation, the heart is racing, and they're partially waking up, etc. Mm-hmm. Now, if I do that strong breath hold during the day, it will tend to activate the same sequence. Mm-hmm. So once we see that happening, we say, no, you can't do strong breath holds. However, you don't have to just do the strong breath holds to get changes to breathing. Cadence breathing we do, down to 6 breaths per minute. Slow breathing, functional breathing, nose breathing during physical exercise, especially for recreational runners. I wrote an article for Men's Health. It will be published in August. Anytime you Google breathing during running, it's all about mouth breathing. But it doesn't really make sense to me, because if you go for a run, you need to improve oxygen uptake and delivery to the cells. And if you're running with your mouth open, you're ventilating mainly the upper part of the lungs. But where the blood is in the lower lobes. And the other thing is, we're breathing fast and shallow with mouth breathing, because mouth breathing, there's no resistance to breathing. So it doesn't make sense in terms of breathing efficiency if individuals switch from mouth to nose breathing, and if they slow down their respiratory rate and only take enough air that they're needing, they will increase their breathing efficiency by about 15 to 20%. Their recovery is better. There's less trauma on the airways. So say, for example, individuals who are prone to exercise-induced bronchoconstriction. Somebody goes out for a long run and they find the next day that their airways are feeling inflamed, both their throat, their lungs, etc., because moisture has been sucked out of the airways due to the excessive breathing over that period of time. And by switching to nasal breathing, we have to bear in mind, what are the functions of the nose? Moisten, regulate volume. Your nose is directly linked with your diaphragm. Your mouth is directly linked with the upper chest. You can't breathe as effectively using the diaphragm if you continue breathing through the mouth. Your nose is moistening, warming, filtering, and all of this is protecting the airways. And with a good airway, we can ensure and help ensure an adequate oxygen transfer take place.
Yeah, I've been trying to do that. I've switched to nose breathing. I'm one of these people that, a lot of things happen for a reason. And several years ago, I came in encounter with a Navy SEAL that actually was it was a retired SEAL. He was a salesman, and we were talking about stress equipment. And he asked me, I said I was a runner, and he asked me, "Do you breathe through your nose or your mouth?" And it's like, well, I don't know. I breathe, it's like I breathe, however I can get air in my mouth, a mouth. And I didn't really think. And he's like, they teach us controlled breathing and to breathe through a nose, and it's, so I tried it for a few times. Like, well, this is too hard, and I quit. Sure. And of course, after I read your book, and some other things, I've gone out and especially, and I try to breathe almost exclusively through my nose. Now, it's not easy. No. I have to tell myself, I've done the pulse ox work, and I have to tell myself it's not because of your oxygen, it's because of, the resistance and training. I'm training my respiratory muscles, my diaphragm, yes. My rib muscles. Yes. And I have to slow things down. And once I get settled into it, yes. It becomes much easier. Yes. A few points on it, if I'd like to make it just when it's in my mind. Number one is always go easy for the first 15 minutes. If you launch too quickly into it, the body needs to be very much warmed up. Nasal breathing then, because then you have your more regular breathing pattern. Number two is the size of the nostrils. Black people have better nasal function, better, wider nostrils than Caucasians, than Europeans. It may be necessary to wear a nasal dilator. So even if we have breathing efficiency, we have to consider the airway. So if I'm going for a run, I will use a nasal dilator because I've really compromised nose. Mm-hmm. And probably years of mouth breathing as a kid. I've got a high palate, pinched nostrils, all of that stuff. So the nasal dilator is based on the Cottle maneuver. If you just put one finger either side of your nose, mm-hmm. and just gently prise the nostrils, it's helping to open up. There are products for sports that are fairly, and I'm not financially involved with them. One is called the Turbine. The Turbine I tend to like more because it's a plastic dilator that it's not sticky. It's something you put into the nose to open up the nose. If we use breathe right strips with the sweat, they tend to come off. So the Turbine is a good approach there. And the other thing is to have, anybody who is switching to nasal breathing, yes, initially you will be slowed down because it's adding an extra load onto the diaphragm and to the breathing muscles, but this is helping to condition them. And with time then, and also as your BOLT score improves, your ability then to adopt nasal breathing is improved sufficiently. There's a dentist in Los Angeles called Dr. William Hang. He's an orthodontist, and he's running marathons for many, many years. And here's an orthodontist who is fascinated by airway. A lot of his work is people flying in from around the world to reopen these spaces where they had teeth extracted as kids, and when their airway was made smaller, and then they developed sleep apnea. So these are individuals, maybe as adults coming in, they're coming to Dr. Hang to reverse the orthodontics that they had as children because sleep apnea was the problem. But he is an avid runner and nasal breather. I wrote about him in the book, and he's running marathons. The Boston Marathon, I know he ran this year, mouth closed 100% of the time. And I think he must be 65 years of age. I'm not sure exactly, but he must be thereabouts. The other end of that, I'm sure there's a guy named Laird in California that does a lot of hypoxic training. Laird, yes. Yeah. Laird Hamilton. Yeah, Laird Hamilton. And, the other end of it, as far as I think that this is more of a, say if you were going to erase the hypoxic breathing or the rapid breathing to blow off CO2 so that they're, because of the lactic acid buildup in a high explosive type maneuver, that is a little bit different, or for a specific short period as a means of adaptation, just like Wim Hof, and they breathed rapidly to blow off to maintain the oxygen when climbing. So it's a different concept for a short period of time, but not something that we would like to do more on a long-term basis. We want to do the nasal breathing for the most part. These can be specialized breathing techniques for specific areas. Yes. Fast, rapid breathing is a stressor. And by stressing the body in the short term, it's causing the body to make adaptations. But fast, rapid breathing, prior to doing a breath holding, will allow a greater hypoxic response. So if you look at, say, Cox's paper and the Wim Hof method, 30 seconds of hard breathing, followed by a breath hold, the SpO2, the SaO2 drop down to about 80%.
another cycle of fast, rapid breathing breath hold, the SaO2 went down to about 60. And the third cycle, the SaO2 goes down to about 50%. So it's a 50% SaO2. Now, we tend not to do that. Personally, I think it should be only people who have got great resilience, athletes who should do something like that. The vasoconstriction as a result of the hyperventilation, I would be afraid to do it certainly with some of the clients to come into me, because I would hope that they can leave my office fairly comfortably. So I think it suits some people, and it suits those people who are wanting to push to the extremes. I tend to go more with severe hypoxia. I want to drop below 87%, but I don't want to go below 80%. Now, there's times that we do, because the other risk is syncope, hypoxic syncope, as a result. If the SpO2 is dropping down to, say, 60% or below, there's a risk of the individual passing out. So, yeah, I'm very selective about who does the stronger breath holds and who doesn't. And if individuals come in compromised, I'm going to concentrate on nose breathing, cadence breathing, diaphragmatic breathing. And I can do very small breath holds with people, say, with COPD. So I take them normal breath in, normal breath out, pinch their nose, and I get them to walk only about 10 paces. So I deliver a small little hypoxic effect just to cause adaptations and just get a bronchodilation and no more. And because I want to help also reduce the psychological perception of breathlessness, as well as possibly reducing their chemosensitivity to carbon dioxide. Are they breathing hard because of airway obstruction, or are they breathing hard because of the increased chemosensitivity to the gas CO2? And the same question we would ask with people with cardiovascular issues. Ascending altitude, again, that comes down to increase oxygen uptake by slowing the respiratory rate but breathing deeper, so that each breath that you're taking into the body, a larger amount of air is reaching the small air sacs where the gas exchange can take place. Fast, shallow breathing, not going to do it.
Very, very, very interesting. And in your book, you also talk about you're not really a fan of counting. It's more about just focusing on the breath to get to do the technique right.
Yes. Now, some of the exercises we do count.
Right.
But for 15 years, we were absolutely no counting. And the reason being was because, say, if I have a client coming in and the client is breathing 20 breaths per minute, and if I say to the client, you're breathing as much too fast, I want you to bring the respiratory rate from 20 breaths down to 10 breaths. Well, what will happen is they will reduce the respiratory rate, but at the same time, the size of each breath will increase disproportionately. So they end up hyperventilating. So that's why we're always frowning. Don't count your breathing. Just soften the breath. You're feeling the airflow coming in, you're feeling the airflow leaving, and gently soften and slow down the speed of air as it comes into the body. And really have a relaxed, gentle, slow breath out to create air hunger, to expose the body to the increased air hunger, to change the breathing pattern. But now we have, of course, those exercises, but we also have cadence breathing now, because I think I can't ignore the effect of 6 breaths per minute, a cadence of 6 breaths per minute on heart rate variability, on respiratory sinus arrhythmia, on stimulating the baroreceptors. So, for example, and also the relationship between the sensitivity of the baroreceptors and breath hold time, BOLT score. And again, that wasn't something, this field is increasing and there's nicer links coming in all the time. And so now I've changed. So just some things have changed in the book. The base of it is still perfect. Well, not perfect, but it's still.
It's very interesting because I understand what you mean as far as trying to change. You're driving. It's like, okay, I'm not going to breathe because as one of the last things I'll bring up is the sigh and the yawn. So that all of a sudden, I'll catch myself doing the big breath, and I think that's out of habit for the most part.
Yes. Like a sigh every now and again, no problem. A yawn every now and again, no problem. It's individuals, say, coming in with high anxiety, panic disorder, which such a strong sensitivity to the buildup of CO2. They would be sighing every few minutes. Big problem. And I always actively encourage them, because I know if they continue sighing, they'll maintain that breathing pattern. And we really have to be looking at the physiological aspects of breathing and how that's impacting anxiety. A Cochrane review looked at dysfunctional breathing patterns in the Western population, and it concluded it affects 9.5% of the Western population. Another paper looked at the incidence of breathing pattern disorders. In the asthma population, it's 30%, but in the anxiety population, it's 75%.
Wow.
75% of the anxiety and panic disorder population. And yes, one could say, well, they've got anxiety, which is going to make you breathe harder and faster and more upper chest. But it's this harder and faster and upper chest breathing that's feeding back into the anxiety. The diaphragm is not just a breathing muscle, but there's a link between the diaphragm and the emotions. And there's also a link, slow breathing and the emotions. Stanford Medical School in March of 2017, they identified a new structure in the brain in the locus coeruleus. And they said that this structure in the brain is literally spying on your breathing. And if you breathe fast, this structure in the brain will relay signals of agitation to the rest of the brain. But if you really slow down your breathing, this structure will relay signals of calm. And this structure also plays a role in sleep. So at the very start, we spoke about arousal threshold. We want deep sleep. How do you achieve it? Nose breathing, slow breathing, and diaphragmatic breathing.
Very, very good. It's such an interesting field. I mean, I have just really, got into it. And like I said, I've been looking at my patients, looking at myself, looking at running. And it's been a very, very interesting. And I'll enjoy watching your work as you proceed, because
Sure.
it's really interesting. I have to say, I ran the Dublin Marathon.
Wow.
I think it was like 2010, but you went to Trinity College, I believe,
Yes.
right? So
Yes, yes.
around all that. So it was, I was excited to be able to speak to you. I haven't been back to Dublin since, but it was one of our
Yes.
favorite trips. My daughter and I and some friends went there, and the
Great.
people were just fantastic. It was a beautiful country. We had such a great time. The other off breathing. So my name is Dulaney, right?
I know, and it should be spelled Delaney.
Yes, and it's so funny because that was exactly what I was going to ask you. I said, are there any DUs? Because my uncle, when he was in the service, they changed it to DE, and he kept it. So I actually have,
Yes.
and it's funny. It's like, so I'm not a real Irishman because I have the DULANEY.
No, what happened in many instances that when people were leaving Ireland and they were going over to Ellis Island, or wherever the port of entry was, the immigration official would ask them their name. And maybe your ancestor said, well, my name is Patrick Dulaney. And it was the immigration official that filled it out, who spelt it incorrectly. And that's how it ended up. So we see a lot of the Irish names that they're not spelled, they read the same way, but they're not spelled the same way. And I think it's because of the immigration officials.
Yeah. So I wish it was DE, but I have to go with the DU. And my last Irish question is, so we just released a cookbook on plant-based nutrition, and it's dedicated to my grandmother, who was an Irish cook. And
Great.
She made this bread that used potatoes to ferment rather than yeast. And the history that I have goes that, because block yeast wasn't available, she would ferment these potatoes and get this foam and start this bread. Have you ever heard of this kind of a bread?
There is a potato bread. I remember eating it as a child. I haven't seen it so much, but there is a reason why we had such an emphasis on potato, because during colonization, it was the main crop because we could get so much yield out of a small, like if you see the land where we are living, I'm in the west side of the country, so there would have been a lot of potatoes grown because it was the best crop to get the maximum yield. So it would make sense that the bread was potato bread. And it was nice, by the way. I remember eating it as a kid. It was very nice.
Yeah, it's very dense and a thick bread. Yes. And so it's a heritage that I have kept. And again, like I said, we just published it in the beginning of this cookbook so that we could keep that tradition going. Great.
That's great to hear.
Well, listen, I thank you so much for your time, and I'm glad we could connect. And it's been my pleasure.
Yeah, and listen, thanks very much, Jami, because We would love to see more cardiologists looking at the whole relationship between breathing and how it can make an impact, and sleep. And that connection is something that we can't ignore.
All right. Well, I'll send you a little update from time to time looking at my practice and what we've accomplished. How about that?
Excellent. Thanks very much.
Thank you very much. Have a nice day. Bye-bye.
Bye-bye.
I hope you enjoyed the interview with Patrick. I certainly did, and learned a lot. It's certainly worth a couple listens, because there's a lot of things that you can pick up on that he was speaking about. Again, his book is called The Oxygen Advantage. He has a website, Oxygen Advantage, and he's on social media and Facebook, all one word, The Oxygen Advantage. I'll obviously put it in the show notes. And he's also on Instagram, Oxygen Advantage. So check out his work. Certainly check out the book. Check out our cookbook if you haven't got it. We'd love to have a review on Amazon. So get those recipes going, and I hope you enjoy it. You can get a link to the book on our website, or you can go directly to Amazon. And we look forward to hearing from you. If you want to email me at jami@drdulaney.com with any other questions, it's jami@drdulaney.com. Also, at drdulaney.com, you'll find that not only am I doing a weekly blog post, but Addie is putting out, our registered dietitian, another very informative blog post every other week. So please check those out. There's lots of good tips. If you haven't signed up for our newsletter, go ahead and do that. We have wellness information, practice information, as well as a recipe of the month. So that's all free. So check us out, and I'll talk to you next week. Thank you for listening.